Breathing, it's the very first thing we do when we're born, and the last thing we do when we leave. But what happens when that simple, automatic act becomes a daily fight? For millions of people with asthma and COPD, every single breath can be a struggle. So let's get right into our respiratory rescue mission and break down the medications that help win that battle. So take a look at this. On the left, you're seeing an asthmatic airway. It's inflamed, swollen, and tight. It's basically like trying to breathe through a pinched straw. Then on the right, with COPD, you can see the tiny air sacs, the alveoli, are actually damaged and have lost their stretch. Both of these make it incredibly difficult to move air. This visual really sets the stage for what our meds are trying to fix.
So when your lungs decide to, revolt, we're basically fighting on two fronts. First up is bronchospasm. That's that sudden, vice-like squeezing of your airways. And then there's chronic inflammation, that constant low-level irritation that's just waiting to cause the next big flare-up.
And this is super important because it shows us why these two conditions, even though they seem similar, are treated a bit differently. With asthma, that obstruction is often reversible. We can actually open those airways back up. But with COPD, as you can see, that damage is usually permanent, and it's made even worse by all that extra mucus. This difference right here is key to our whole treatment strategy. Okay, let's meet our heroes. First up, we've got the bronchodilators. I want you to think of these guys as the paramedics of respiratory care. When the airways are clamping down, they are the first responders on the scene, and their only mission is to open things up and do it fast. The leaders of this paramedic team are the beta-2 adrenergic agonists. Their job is to tell those smooth muscles squeezing the airways to just relax. And here's a fantastic memory trick for you. Their generic names almost always end in "terl," like the most famous one, albuterol. So how do these minestrol drugs actually work their magic? Well, they tap into your body's fight-or-flight response. The sympathetic nervous system. It's that ancient hardwired alarm system that gets your body ready for some serious action. And this picture? It's perfect. It shows you exactly why this is so useful. If you're running from a tiger, you need your airways wide open to suck in as much oxygen as possible, right? Well, these terterol drugs trick your body into creating that exact same effect. But instead of running from a tiger, you're fighting off a bronchospasm. But, and this is a big but, not all of these drugs are the same. We got to split them into two teams. You've got your sprinters and your marathon runners. The SABAs, like albuterol, are short-acting. They're your rescue team for an immediate attack. Then you have the LABAs, like salmeterol. They're long-acting. They're for daily, scheduled control, definitely not for emergencies. All right, pop quiz time. Let's say you're teaching a patient about their albuterol inhaler. What are you going to tell them? A, use it on a strict schedule, every 12 hours. Or B, use it when you need it, like to prevent an asthma attack before you exercise. Take a second, think about it. And if you said B, you nailed it. Albuterol is a SABA, a sprinter, a rescue inhaler. It's perfect for heading off an attack you know is coming, like from exercise, if you take it about 30 minutes before you start. Option A, that's describing a LABA, a long-term controller medication. So you can see why knowing the difference is absolutely critical. Now let's meet the other half of our first responder duo, the anticholinergics. So if the beta-2 agonists turn on fight or flight, these guys do kind of the opposite. They block the rest and digest system. And what's cool is this not only helps open the airways, but it also helps dry up all that extra mucus. This table just lays it out perfectly for us. On one side, you've got the beta-2 agonists activating fight or flight, which can sometimes cause side effects like a racing heart, tachycardia, or some shakiness. On the other side, the anticholinergics block rest and digest, leading to totally different things like dry mouth. Two different paths to the same goal, open airways. Okay, so opening the airways is fantastic for that immediate relief, right? But it doesn't solve the real underlying problem, which is that chronic inflammation. For that, we need a totally different kind of hero. We need a long-term guardian. And that's where the glucocorticoids come in. Hey, here's another memory trick for you. These often end in "-sone." Think prednisone or fluticasone. Their whole mission is to calm everything down, suppress that inflammation, and stop future attacks before they even start. They are the definition of a controller medication. We can get these steroids into the body in two main ways. Inhaled steroids, like fluticasone, are what you use every day for long-term control. And because they go right to the lungs, they have way fewer side effects throughout the rest of your body. Then you have oral steroids, like prednisone.
These are the big guns we use for short bursts after a really bad flare-up to just stomp out that inflammation quickly.
Okay, these drugs are absolute lifesavers, but, and there's always a but, they come with risks. Patient safety is everything, so let's lock in the most important side effects with a couple of quick and easy memory tricks. For the anticholinergics, this classic mnemonic is pure gold. They dry everything up so you can't see because they can mess with eye pressure, can't pee from urinary retention, and can't spit from that dry mouth. It's a little cheeky, I know, but trust me, you'll never forget it. Out of all of those, the one you'll hear about the most is definitely dry mouth. And this is some super important patient teaching. Simple things like sucking on hard candy, chewing some sugar-free gum, or just taking little sips of water can make a massive difference for your patients.
And now for steroids. This one is huge. I want you to burn the 5 S's into your brain. S is for sepsis because they lower your immune system. S is for sugar because they can cause high blood sugar. S is for swelling from holding on to fluid. S is for sight because of a long-term risk of cataracts. And finally, S is for skeletal because they can weaken bones over time. And this slide, wow, it gives us a really powerful look at what can happen when those side effects, especially from long-term oral steroid use, become visible. This is what we call Cushingoid syndrome. You can see symptoms like that moon face from all the fluid and the classic buffalo hump. It's a pretty strong reminder of why we always aim to use the lowest dose possible for the shortest time necessary. So, knowing all the meds is half the battle, but using them the right way, that's how you actually win the game. Let's wrap this up with a super clear, actionable game plan to keep things safe and effective. Okay, let's put it all together. This is your order of operations. Number 1, always use your bronchodilator first. You have to open up the airways so the next med can actually get down in there. Number 2, give it a few minutes, maybe 5. Number 3, after you use a steroid inhaler, you have got to rinse your mouth with water. This prevents a nasty fungal infection called thrush. And finally, this is a major safety alert. If you find yourself reaching for that rescue inhaler more than twice a week, your asthma is not under control and you need to call your doctor.
Look, we've covered a ton of ground here, from fight or flight to the 5 S's of steroids. But this is just the beginning. The goal here is to empower you. So the real takeaway is this. What's one question that this made you think of that you can ask your doctor or your pharmacist next time you see them? Because taking control really starts with asking the right questions.